Okay, in this session we're going to talk about head and spine trauma. We're going to focus on trauma that involves either the soft tissue of the head, the bony skull of the head, and then of course obviously the brain and the spinal cord and the spinous processes of the vertebrae. We're going to save the facial and neck trauma for another segment, but we'll refer to that whole area because it's all connected. So often if you have an injury to one of those four, you have an injury to the other ones. Alright, so breaking it down, we'll start with the scalp. So the scalp is very vascular, has a lot of soft tissue that covers it, and these bleeds can look insane. There can be just a ton of blood from a scalp injury, and you finally get down to the source and you see that it's this 3 millimeter lac, and it looks like it dumped a gallon of blood. So just don't get distracted by those injuries. They can be very distracting, I know, but don't let that blood distract you from figuring out what's going on with the ABCs. Now you also can't just write that blood loss off, because there is because it is has such propensity to bleed, but usually if there's nothing broken underneath it, you can apply a little gentle pressure and it will occlude. Okay, looking at the skull itself, obviously it's made of pretty tough bone. It doesn't really give, which causes us a problem when we have an injury to the brain inside, because any swelling that occurs puts direct pressure on the brain, because that skull is not movable. Starts out a little bit more pliable when you're born, but then those sutures that go in between all of those flat bones there tend to seal up and are much less movable. So again, any damage to that brain, anything to the inside of it that causes swelling, causes quite a bit of issue, because the swelling has nowhere to go, except this hole here. And what's that hole again? That foramen magnum, where the spinal cord comes through. That's the spot that is the only real open spot for the brain to move through. So you'll see when you get a lot of extra pressure in that brain vault that it starts to compress, and eventually it can actually push its way down through that foramen magnum. The bones on the other side of the skull here is the crubiform plate, where the brain actually sits, and it's a little rough, and because it's meant to kind of hold the brain in place, but this becomes an issue as we age and our brain shrinks, and now that brain has a little bit more give, a little bit more room to slosh around in there, and if there's an impact or a fall, sudden acceleration or deceleration, I can actually move that brain across that plate, and you can actually have damage to vessels and to that soft tissue there. So you might have some issues that way. Speaking of the brain, obviously it contains billions of neurons and does all of these incredibly vital functions for us, right? It's about 2% of our body weight overall, and it's very sensitive. It likes a certain pH, it likes a certain amount of sugar in the system, and it needs oxygen obviously too. In fact, if it goes without oxygen for as little as 5 to 10 seconds, you can become unresponsive. So it's pretty sensitive, but it's, again, we talked about this in the neuro lecture, it also is pretty resilient, because it doesn't just completely shut down all at once. It starts to shut down slowly, and you go through all those stages of being anxious first, and then all the way down through unresponsive. And depending on the insult, it just happens that much faster or slower. All right. Also, break down the spine. You have 33 bones or 33 vertebrae divided into 5 sections, and somebody once told me, I think it was Mark Kaminsky, had a good way to remember. So you eat breakfast at 7, there's 7 cervical spines. You eat lunch at 12, there's 12 thoracic vertebrae. You eat dinner at 5, there's 5 lumbar. And then you get a snack at 9, which is a combination between the sacrum and the coccyx. So there's 9 between there. So I thought that was a good way to remember the regions of the spine and how many vertebrae are in each of those regions. Even though we're not going into specific details in this lecture about it, I did still want to cover the neck itself, because you have a lot of blood vessels in here, and in addition to all the soft tissue that goes across the face, you also have a lot of vasculature that runs through here, nerves that run through here, so it's definitely something to be concerned with. And again, if you have an injury to the head, to the neck, you could have an injury to the spine and to the face as well. So kind of got to cover it all at once. All right. So just starting with our assessment, obviously we need to assess our scene safety, figure out what's going on, and then determine what BSI we need, right? So, and we have to be most concerned with ourselves. Now, each different scene has its own dangers for us, but it also allows us to be suspicious of what is happening with our patients. So if we're looking at MVAs or falls, we're thinking of head injuries or possible spine injuries. When somebody's had a direct blow to the head or to the back, or we're worried about those things. Assaults usually involve the head, the neck, and have potential for spinal and brain damage as well. And then sports-related injuries. We see a lot of spinal and head injuries related to sports, whether it's a concussion, whether or not it's a stinger, or something more minor that recovers very quickly. It just has the high propensity for danger there. All right, we're going to talk a lot about spinal immobilization here, and a lot of the changes that are occurring with spinal immobilization. And even though you'll hear people say, oh, we never use backboards anymore, that's not entirely true. We do still use spinal immobilization when it's indicated, and there are definitely times when it's indicated. And if nothing else, we should be considering the different mechanisms of injury that could lead to spinal damage. And while we're not basing everything off of mechanism of injury anymore, that mechanism of injury should increase our index of suspicion that there's head trauma or spinal trauma involved. What are some of those mechanisms? High velocity crashes. If you have high-speed roads, if you have two highways where people are traveling at 50, 60 miles an hour and somebody crosses left of center, so you get a head-on collision on those high-speed roads, it's incredibly dangerous. There's so much force relayed there. Remember, because if they're coming towards each other, their speeds actually add on to each other. So you get, if both cars were traveling at 60 and they hit, that's as if they were traveling at 120 miles an hour and came to a stop. Same thing with our country roads. You see a lot of just accidents on country roads where people are just cruising along and they either fall asleep or lose control and hit a tree or a pole, and they were going 60, 65 miles an hour down those roads. All right, so definitely high velocity crashes. And the damage to the vehicle that you're looking at is you're looking at patient compartment damage. A lot of the newer cars are meant to absorb some of that shock, so that those forces are not transmitted down to the patient. So they look awful when they're in a crash. But you have to immediately assess the passenger compartment. So where is my patient? Was there any intrusion into that compartment? How much intrusion? Where did it hit? We're looking at, all of those things that go along with it. When people are unrestrained, that adds a level of damage there. Those seatbelts are there for a reason. So when they're not utilized, that causes an issue. Falls for adults, they say 3 times, a person's height, or general 20 feet. For kids, it's less than 10 feet. And again, that a couple times their height is a big thing. And then for geriatric patients, it's really from standing, because as we just discussed, the brain shrinks over time. So when somebody goes from standing to hitting the ground, there's a little bit more space in that skull. That brain's able to slosh around a little bit more and hit the insides of that skull. So definitely issues there. And then you have penetrating trauma. That's another issue. Any penetrating trauma that happens, near the spine, or that we suspect could have been near the spine. So a gunshot wound definitely could, make its way towards the spine. So we have to be worried about that. We don't know where that bullet went. We don't know where fragments went. So it's something that we should be considering. So even though we wouldn't backboard somebody just based on mechanism of injury, we would consider that mechanism of injury when we're evaluating our patient and looking for damage. So it should at least clue us off that we have to check to see if we need to backboard somebody. All right, more things that go along with that. I think we talked about this, but maybe not. I know we talked about unrestrained, but somebody who's ejected from a vehicle. All right, that's, they're flying through the air. They're, now a projectile themselves. They're going to, not only whatever force was there to move them out of the car, they're also going to hit the ground. So that's, a lot of potential for damage. Motorcycle crashes, again, they're not protected by a vehicle around them. If they're a pedestrian, again, not protected, or on a bicycle. That's another issue. Anytime you have pedestrian or cyclist versus car, it doesn't turn out well for the pedestrian or the cyclist. And even bicycle crashes on their own, over 20 miles an hour, that's a lot of force to hit the ground with. So that's another, concern that we could have. Death of an occupant in the same compartment, that means that there was a lot of force there. It was enough to kill somebody. And unrestrained rollovers in particular are an issue. With rollovers, it seems that people are either perfectly fine or they're dead. There's very little in between with rollovers, and usually those unrestrained folks are tossed around in that compartment and exhibit many more injuries, or they're ejected. When they're restrained, a lot of times they tend to just crawl out of the vehicle on their own because they were held in place by those restraints and are just fine. All right, so we're going to do our survey, and if it's something that we think could have the possibility of having spinal damage, then we need to take cervical spine precautions and manually stabilize that cervical spine. We're going to determine our level of consciousness, obviously, as we're walking up to the patient. We want to make sure that we're facing them so they're not turning their head to see us, because if they had spinal damage and then they turn their head to see us, that could actually cause even more damage. So we're determining their level of consciousness, we're approaching them and checking out if they're able to talk to us, if they're alert and oriented. Does that airway open? Do I hear gurgling, how's their breathing, what is their skin color and condition as I'm approaching to tell me about circulation. And then we really need to get a quick assessment of pulse, motory, and sensory. So going through, doing hand grasps, doing push-pulls on the feet, just to get a quick sense of where they are. And then, before we leave that manual stabilization of the C-spine and turn that over to somebody, we're going to evaluate the need if they need a C-collar, put that on them if we've decided, and then have somebody else hold manual C-spine as we work our way down the patient. All right. Just like everything, right? Airway breathing is incredibly important. So we need to make sure their airways are open. If, depending on, what damage is done, they may not be breathing very well on their own. We may need to ventilate them. If somebody has a head injury, they're much more likely to have feelings of nausea and they may vomit. So we need to be prepared to roll. And this is why we have manual stabilization of the C-spine area until we get those head blocks on. And that's why we strap down the patient to the backboard, their body first before we put the head strapped in, because we want to make sure that if we have to log roll them, that we're not going to contort their spine as we do that. And again, all these injuries go hand in hand, but if you have facial trauma, we're not going to be putting stuff in their nose just because we don't know the extent of that damage. So we may not use nasal airways during that case, especially if you have fluids coming from the nose or suspected fractures in that area. We're going to look for other routes. One of the things that and again, this is just nothing in the nose, but we may have to move to secure that advanced airway a little bit faster, and that is key. And because of that, and because of their head injury type status and what their level of consciousness and awareness might be, we may need to consider sedation before managing that airway. And that might be so that we can control the airway, in addition to just allowing them to calm down enough for us to manage that airway. All right, so again, going back to that ventilation, we can give a non-rebreather if that patient is breathing adequately. If they're not breathing adequately, then we need to do the ventilations for them. And there's no real reason for us to withhold oxygen from these patients. Better to put it on them and get it going, and then we can always back it off if need be. We'll talk a little bit about hyperoxygenation. This is also another thing that is up for debate right now. They're going back and forth on it a little bit. We used to call it hyperventilation, where we would bag them at a rapid rate, and then now we're trying to call it hyperoxygenation, or just bagging them on the high side of normal. So it's not that we're bagging them at 40 times a minute or 60 times a minute or anything. We're just bagging them on the high side of normal. So we're going to bag them at 20 for our adult patients. All right. We're looking and we're assessing our circulation. Remember, those head injuries can bleed like crazy. So, we might want to we'll have to put something on there. You don't want to put a lot of pressure to stop that, because if there is any depressed skull fractures or anything underneath that injury, we obviously don't want to be pushing that bone in towards the brain. And but we'll at least be able to palpate, feel for crepitus, and put a reasonable amount of pressure on those bleeds. And then we have to think about supplementing that fluid loss. All right, so if they're pale, cool, and clammy, then we're going to think about giving some fluids because they look shocky. the big difference there, the big thing that we have to watch for, is neurogenic shock. Because remember, neurogenic shock doesn't really look like shock initially. When you're in neurogenic shock, those controls to the vasculature have been cut off. So there's nothing telling the vasculature to clamp down like we would see with normal shock. In normal shock, we see all these signals going to everything near the skin, telling those arteries to clamp down, to reduce blood flow to the skin, to try to, one, dump the blood flow back to the core, to those organs that need it, and then also to keep it away from the skin so that it doesn't cool as quickly. So they're trying to conserve their warmth. But in neurogenic shock, there are no signals. Nobody's telling that vasculature to close down. So everything opens. So all the blood is free to flow to the skin. So how does it look then? Well, it looks nice and pink. It feels nice and warm, and it's dry. They might even have a flushed look about them at first. So you look at them and you think, they look pretty good. And it's not until later that you realize that they were neurogenic shock, and they'll start cooling down rapidly because everything's open to the periphery. All right, so if we need to do fluid loss, we're going to give saline. We're going to stay away from anything with dextrose in it, and I don't know of anybody around here who carries that as a first line fluid anyway. But we want to watch that because it can actually increase our edema in the brain. Remember, that's a hypotonic solution, so that fluid from that solution will rush into the tissues, which could cause further swelling and edema. Things to consider is if somebody has a head injury, or we suspect that they have a head injury, we don't want to just keep pumping fluids into them and increasing their blood pressure, because that's just going to increase the rate of their fluid loss in the head cavity, and remember, there's nowhere for that to go. So we want to try to limit our fluids to just to the point of perfusing. Alright, so assessing, so we've covered A, B, and C. We need to assess disability and expose the patient. As far as their disability, we're looking at their level of consciousness, their response to stimuli. Are they alert and oriented? Do they only open their eyes when you talk to them? Are they able to follow commands? And checking those MSPs. So, can you wiggle your fingers? Can you tell me which side I'm touching? Can you squeeze my hand? And doing the same thing for the feet. And then doing our full body assessment to see what's going on with our patients. We want to expose, we're going to visualize, we're going to palpate, and then we're going to listen to lung sounds and things like that. So we're using all of our senses to check on them. Where whenever we're looking at the spinal column, we're just like any other trauma, we're looking for deformities, contusions, abrasions, all of those things, the DCAP, BTLS. And specifically, we're looking for step-off fractures, where you can actually feel that fracture and that dislocation of the bone out, so it literally has like a step in it. We're looking for point tenderness, so no pain, no pain, no pain. You touch a certain spot and there's pain there. And then we're also, checking for crepitus, that bone movement on each other. Alright, so as we are continuing with our assessment, that'll also help us to determine if we need full spinal immobilization. And I'm going to get ready to figure out what's going on. Obviously, assessing our level of consciousness is important, and establishing our baseline for our neuro assessment. Very important for us to do a full-blown neuro assessment here. So we're looking at, again, level of consciousness, can they follow commands, are they completely alert and oriented, ×4, answering to person, place, situation, and time, and obtaining a GCS, because that GCS is our universal language, basically, so that everybody knows about where we stand. If they're at a 15, then we know mentally and responsive wise they're good to go. If we're down at a 3, not so good. Remember, if they're at an 8, what is it? We think to intubate. So, it gives us just a scale that we can look at and understand. And then it gives us something to go off of. So as we trend what's happening with our patient, are they going up, are they going down, what's happening? All right, that level of consciousness really, helps us determine that brain dysfunction, if the brain's been impacted, if they're able to answer our questions, if they're able to follow simple commands. And really, that's going to be our window into how that brain's doing, what's going on with them. And then we really need to decide what we're going to do, right? We have to determine our plan. We have to decide where they're going and how we're going to get them there. And that will be based on all of those things that, we've just talked about with our ABCs, and then that disability and exposure, what are we seeing? For these folks, if there is head spinal damage, they might require surgery, and we're going to have to determine what that damage to the spine is and how much immobilization we're going to do. Like I mentioned, there's a big debate right now about, the use of backboards. And I think we really have to understand that debate to understand whether or not we are going to use them. When we're going to use them, right? So if we're just using it to immobilize, maybe they have some long bone fractures, we're just using it as basically a full body splint. But the patient is alert and oriented, answering all of our questions appropriately, and we're able to manage them. They're breathing on their own. That's less critical. We have a little bit more time to worry about placing that backboard. If the patient is, critical, is not doing well, then we might even put them on the backboard, taking them out of the vehicle, or we're going to do the rest of our assessment after we get them out. So it's really just going to depend on the condition of your patient, where they are, how they're there, and what kind of access we have. So it used to be that we just backboarded everybody that was trauma. Like you had any possible slight chance of having spinal damage and you got a backboard, because they felt that it was a pretty benign procedure. It wasn't really hurting anybody. It's just very precautionary. And then what they found was there was actually damage being done. So something that they thought was very benign, something that they thought was no damage associated to it, they were starting to see damage. Whether that was just somebody developing bed sores, and then from the pressure points, because backboard is very uncomfortable, and then those bed sores becoming infected and causing further damage for that patient, or if it was the discomfort itself increasing the pain, which, as we've learned, increases the time the healing time required, or if it's something just as not simple, but something that is big right now is patient satisfaction and how they felt that they were treated. And people on backboards are very uncomfortable, and they tend to give very low ratings when they're on a board. So I would hope that it would be more driven by the actual condition of the patient and less driven by the scores and then the funding that they would get based on those scores. But it's up for debate. I know that there were several cases where somebody was on a board and they were put in a back room and they were basically forgotten there. And if you've ever been completely immobilized on a backboard, it's difficult to get yourself out. And especially, if you're not at all familiar with the equipment, or you think that I have this equipment on, if I take it off, I'm going to cause more damage to myself. There's a big issue there. So they were having patients that were just left on a board in a back room, and nobody was going and checking on them for hours at a time. And so that was also, a reason for concern. So there's a lot of different reasons why you might not want to put somebody on a backboard. But then there's also reasons why you might want to use a backboard or use some sort of spinal immobilization. So maybe it's not a backboard, maybe you're using a vacuum mattress. You're just doing something to protect their spine. So things to consider. Here's some more of those negative effects of using a backboard. You have, is there anything I didn't cover? So yeah, pressure sores and ulcers, we talked about that. General pain. The other issues is respiratory compromise. Folks that have CHF, folks that have respiratory issues, don't like to be laid down, right? They feel like they can't breathe more. If they do have fluid in their lungs, then laying down allows that fluid to shift and makes it much more difficult for them to breathe. So there's an issue when you have somebody laying flat on their back on a backboard. Also, people putting on collars incorrectly or using them incorrectly can cause further damage. Again, if they're all strapped down, they can't move on their own, they have increased risk of aspiration. And if you are managing their airway, it's very difficult to manage them when they're in those positions. So we do have to, watch those things as well. But again, understand that this is still a very rapidly changing treatment, a rapidly changing part of EMS. It's something that we're watching the change take place right now. And while there have been standards for the last few years, people still aren't quite sure how to use them. So you have folks that have been doing this for 20 years who pretty much everybody still gets a backboard. And then you have, folks that are a little bit more progressive that are really trying to evaluate somebody properly to decide whether or not they should get a backboard. But really, you need to take it on a case-by-case basis, and we'll actually go through the spinal protocols that are put out by UH and by a lot of companies around here. And I know, I believe that AJ mentioned the other day how it's dependent on where you're working too. So Metro, when you go to fly them on Metro, they want them to be on a backboard, right? That's how they want them packaged. So we have to be aware of that. But there are other things that we can consider. If we have a minor damage MVA and the patient is complaining of absolutely no cervical or thoracic spine pain, not even on palpation, if there was no change in their mental status, there was no loss of consciousness, they're ANO ×4 answering all of their questions appropriately and able to follow simple commands, and if there are no abnormalities in our MSP assessment, and nothing distracting, so no other injury that could distract them from the pain that they might be feeling in those areas, then they don't really even need a collar, right? They don't need a C-collar, they don't need a backboard. While we'll try to keep them positioned in a neutral position, we're not, spending a great amount of time getting them fully immobilized. And it's different, and it changes as you go. If somebody has all of those things, except they're experiencing a little bit of spinal pain when you palpate their C-spine or their thoracic region, they're complaining of a little bit of pain there, well then we're going to put them on at least on a C-collar and position them on the cot, preferably in a neutral inline method, and we prefer to to transport them supine in that situation. Now, if they have abnormalities there, so if they have changes in their thoracic Okay, so again, if you have somebody who has an altered mental status, who has lost MSPs, or has some abnormality there, or somebody who has who does have a distracting injury. So if they have a fractured leg, or they have some, other injury that could be distracting them from their spinal issues, then you need to immobilize their spine. Now that doesn't necessarily mean that you have to put them on a backboard. We have other, methods that we can use. We could use a vacuum mattress. We could use a vacuum mattress on top of a backboard, which is very handy. We could put padding down on the backboard before we use it, and then pad all their voids. So there are definitely, things that we would want to do spinal immobilization on. And so to just plain say we don't use backboards anymore is not an accurate statement. It's that we evaluate people to see if they need spinal immobilization, and then we try to decide what is the best way to immobilize their spine. Same things with KED boards. Obviously that's a seated spinal immobilization, but if you have somebody who you're concerned about, who you would have wanted to put on a backboard but they couldn't lay flat, or if you have somebody who you're afraid to move them out of the vehicle because of their potential for spinal damage, or that you suspect that they have spinal damage, but otherwise their ABCs are good and they're not critical, then I would take the time to put them on a KED board or some sort of seated immobilization device. I've used a KED board a couple times, and I've used a KED board a couple times for spinal immobilization. I've used it a lot of different times for other things, including, pediatric transport or stabilizing the pelvis, but I've actually used it for inline seated spinal immobilization a few times, and most often that has been when somebody has a history of back issues, or in one case where the guy had just had spinal surgery, had just had discs fused, and was still sore from that whole process, so it was very difficult to determine if his current pain was past pain or if it's new pain. We took the time. He was alert and oriented, and answering all of our questions appropriately. There was no risk to his airway, his breathing, or his circulation, so we took the time to do a seated immobilization there for him. Alright, most often you can log roll a patient, because you do want to check their back, and if you're going to put them on some sort of immobilization device, you need to log roll them, even if you're log rolling them onto a vacuum mattress or something along those lines. Just be careful. So you don't want to roll them onto their broken arm or roll them onto their broken leg. Just be aware of what you're doing and why you're doing it. And when they're talking about reliable patients here, these are patients that you might be able to sign off on spinal immobilization, all right? So they are alert and oriented, they are answering all of your questions appropriately, they are able to follow commands, they have no issues with, comprehending what you're saying or communicating to you. There's no alcohol on board, things along those lines. There's no distracting injury, their neuro exam comes back without any issues, and they have no pain. That happens, like we said, you can sign that person off. All the different ways that you could immobilize them. and things to consider like we talked about. All right. We also want to make sure that they don't just put in a room alone, for the next 4 hours without anybody checking on them. So when you do, backboard your patient, just make sure that you are relaying to whoever you're handing them off to, and while you should be doing a handoff at the bedside and they should be able to see the fact that they're on a backboard, you just want to, kind of remind them and point that out. All right, so enough about backboarding, but really the biggest thing you should take away from it is that you need to be aware of why you might need to immobilize somebody's spine and what things that you can do to reduce other risks. So again, the use of a vacuum mattress is great. Vacuum mattresses are awesome. They relieve the pressure points. They provide that immobilization that you need. They're great for not only spinal injuries, but also if somebody has a fractured hip. It just reduces all of that motion, makes for a much more comfortable ride for them. So, definitely something to be aware of. When we talk about these patients, we're concerned about their neuro, right? So we're concerned about their ability to be historians as well. So we want to make sure that we're getting the history, the best history that we can. So we're going to get our sample history. We're going to be looking for clues. We're going to be following up with questions. If there's anything suspicious, if there's or something that we don't trust, we don't think they're a reliable historian, then maybe we ask people around them just to, corroborate that story. We're doing our secondary assessment. Again, we're just going back over, reevaluating, checking the trends to see, if anything has changed since we first went over them. I feel like we talked about that already. And it's a problem. Sometimes I get ahead of myself since I've looked over these all so much. But obviously, now we're taking a little bit more time. So we're checking the pupils, we're looking in the mouth again, looking in the nose, looking in the ears to see if there's any fluids coming through. And remember that some things become more prominent with time. So periorbital ecchymosis, which is almost as much fun to say as subcutaneous emphysema, is just the bruising around the eyes. It's indicative of facial trauma and skull fractures. That bruising behind the ears, or that those battle signs are indicative of basilar skull fractures. So we're taking a little bit more time to comb through everything to see if there's anything that we missed or anything that was not present when we started and has developed since then. So we need to look over everything. We want to monitor those pupils, making sure they're equal, round, reactive to light, and if there's any changes, are there changes in the size and the shape, or if one's moving, the other one is not, and then obviously looking at the rest of the body as well. All right. Should always be getting a blood sugar on our patients. Abnormal posturing is indicative of intracranial pressure. We're looking for all of those things. We're looking for changes in their respirations. Remember, Cheyne-Stokes respiration is one of those things that would lead us to think that there's intracranial pressure. Same thing with increasing blood pressure with decreasing pulse rate. Those three go together for that triad, and it's all indicative of intracranial pressure. Our neuro exam, like I said before, we have to make sure that we're doing a neuro exam on these patients. We should be doing them on all patients, but definitely those that we suspect of head or spinal trauma. When we're looking at, you'll hear terms like myotomes, and that's just our motor components that are associated with spinal nerves. So it's associated with a certain nerve where it comes off. affects those different muscles. So we wouldn't expect anybody to memorize all of these. It's just something to be aware of. When we're looking at C3 through C5, what do we see there? The diaphragm. That's pretty huge when it comes to respiration. So if we're suspicious of fracture in that area, it's going to make us very aware and make sure we're constantly reassessing their breathing efforts. Dermatomes are regions that correlate with those spinal nerves, and we talked a little bit about this when we talked about shingles. The chickenpox virus will actually lay dormant in the spine, and if it activates later on in life, you'll actually get rashes that correspond right to that nerve root that it was relaying to. And I think we showed signs or showed pictures of those dermatomes before. But so that different part where either you feel and actually the skin itself will actually respond to those different nerve roots. They're all aligned. All right, checking MSPs, push-pulls, can they follow commands? Are their grips equal? Do they have the equal strengths? Are they able to feel which side you're touching, where you're touching, things along those lines? And doing the same thing on the feet. So all extremities, we should be checking those out. If we have a critical patient, we're going to be reassessing every 5 minutes, or basically when you're finished with one assessment, you just start the next. And for our stable patients, we will be looking at every 15 minutes. Anytime you have hypotension without other signs of shock, we're going to be worried about this, especially when it comes to neurogenic shock, which everything else looks okay, but their BP is bottoming. And why is that? It's because their vasculature is not clamping down, so everything's open, so their container just became much bigger, and that dropped their pressure. All right, we're going to constantly reassess what we've done for our patient, and is it helping? Is it not helping? Do we have to do anything else? And one thing that I did want to mention in this part is that obviously the best treatment is prevention. All right, so if we can prevent the injury from ever even happening, then that's best for our patient. So a lot of times we're involved in injury prevention campaigns. So it might be for kids to wear helmets when riding bicycles. It might be for pool safety, and not jumping in, especially if it's shallow, because that's obviously a big risk for C-spine injury. And so you might be involved in some of those, even wearing seat belts, things along those lines. So again, anytime we can help to educate the public on what proper precautions are, what things they can do to reduce their chance of significant injury, even if they do get in a crash, or even if they are exposed, that's part of our job, because prevention is the best medicine. And with that, I believe we're at the end of our assessment portion. There will be a part 2 that talks about specific head and spinal injuries, and a part 3 that discusses those facial and neck injuries.